when you look at the entire picture, we base everything, once you get diagnosed with prostate cancer, on your PSA, on the Gleason score, which Gleason was a famous pathologist that came up with this scoring system for prostate cancer. And it basically goes from a level 6, which is the lowest that we see, to a level 10, which is the highest that we see. 6 is considered low-grade prostate cancer. Gleason 7 is considered intermediate-grade prostate cancer. And then Gleason 8 to 10 is considered high-grade prostate cancer. When you take the Gleason score, the amount of cores that are positive, your PSA, something called PSA density, and you look at the NCCN guidelines, which is sort of the Bible of oncology for any type of doctor or surgeon that deals with cancer. You come up with a sort of a grading system for prostate cancer, and it puts you in categories. One is called very low grade or very low risk prostate cancer, low risk prostate cancer, intermediate risk prostate cancer, and then high risk prostate cancer. And depending on where you fall in those risk categories, sort of dictates what the recommendation will be and what type of treatment you should get. The paradigm in prostate cancer has changed recently. 10 years ago, if you had 1% of one core prostate cancer, you're most likely going to get some type of treatment. You're going to get either your prostate removed, or you're going to get radiation therapy, or you're going to get hormones, or one of those things. But recent studies have shown that sometimes you don't have to do anything for very low grade or very low risk or low risk prostate cancer. We can just watch it. Doesn't mean we're not doing anything. It means that every 3 months, probably get an exam, get your PSA taken. In about a year, if nothing has changed, you probably get another prostate biopsy to make sure that things have not changed. And you may just get watched. It's called active surveillance. And it's becoming more and more popular as more and more research comes out on prostate cancer and its sort of natural history. But that's sort of what has changed in the realm of prostate cancer more recently. The mainstay of treatment, if we're treating for a cure, is either surgery, which these days 80% is probably done robotically, where you have 6 or so ports placed in your abdomen and we fill you up with carbon dioxide. And we go in and remove the prostate and sew the urethra back up to the bladder. Most of the time afterwards, you'll have a catheter in your bladder for about a week. You'll stay in the hospital a couple days. And then after a week, you'll have the catheter removed. Afterwards, most men will have some leakage. They'll need to wear a pad or multiple pads up to about 3 months, where the incontinence starts improving to the point where you may not need a pad at all. Some guys who take out the catheter, they don't leak at all day one. But everybody's a little bit different. Most guys will not need a pad. About 1% of guys may need a second surgery to correct their incontinence. So that's one thing you look at when you look at surgery. The other part of surgery for men is that depending on the nerves, if you can spare the nerves on each side, you're going to develop some erectile dysfunction. And the data is all over the place regarding that. In general, if you can spare both nerves on each side, you'll get your erection back about 70% of the time, with or without the help of Viagra or Cialis or one of those things. If you can only spare one side of the nerves, it's about 50%. If you can't spare either side, it's probably 20% that you'll get your erections back naturally with one of those pills. Now, obviously, there's a lot of other things we can do for erectile dysfunction, but that's sort of the statistics regarding that. That's the surgery aspect. Obviously, it is major surgery, so there's always risks of major surgery, including injury to adjacent organs or structures, something like a heart attack, stroke. I mean, sort of your risk of driving here, getting into a car accident, slow, but it's there. But surgery is one of the mainstays of treatment.